Welcome to Caregiver Relief. I'm your host, Diane Carbo, RN, and today we're talking about something many caregivers face, but few feel prepared for: hard choices at the end of life. When medical technology can prolong life, how do we know when it's helping and when it may be prolonging suffering? My guest today is Steven Cuzmenco. He's a master's prepared nurse. He's also a former cardiac ICU nurse. He's a CPR and advanced resuscitation educator and a PhD nursing researcher. Steven teaches healthcare professionals how to save lives every day. So together, we're going to talk about artificial feedings, ventilators, pacemakers, and defibrillators, what they don't do, and how caregivers can think about the quality of life alongside quantity of life. This is a conversation rooted in compassion, honesty, and support for caregivers walking these decisions right now. This episode is sponsored by myvitalvault.net, your all-in-one life organizer for aging adults and caregivers. It's designed to help you securely store your essential legal, medical, and emergency information in one easy-to-access place. Because when a crisis hits, being prepared can make all the difference. Join our Caregiver Relief community, a warm, welcoming space where you can connect with other caregivers, ask questions, share stories, and find support from people who truly understand. Visit community.caregiverrelief.com to join now, because caregiving is one of the hardest and most meaningful things you'll ever do, and no one should have to do it alone. And if this episode speaks to you, please take a moment to like, share, or comment. Every click helps us reach more caregivers who need encouragement, resources, and hope. Thank you, Steve. I know you are on the professional side of teaching the healthcare practitioners. Tell us more about what you do and how you do it.
Absolutely, Diana. So thank you for having me, and I look forward to sharing what I know. I certainly don't know everything, and I am a prospective PhD nursing researcher, still in school to obtain my PhD, but hopefully going to do resuscitation science research and help the teams with resuscitation in the hospital and out of hospital settings. So what I do is I work for a large hospital organization in the southeast of the United States. And within that, I work for the life support education department. A lot of these larger institutions that are well developed have them. Some of the smaller hospitals may not. They may have one instructor, but my hospital has a whole department, and others do as well. And so day to day, my work is surrounded with resuscitation, either training or resuscitation process improvement. And that encompasses a wide lens. That's from the early recognition of cardiac arrest or peri-arrest, what we like to call, all the way to helping people recover. So that survivorship, you experienced cardiac arrest, you had a long stint in the hospital, you might be at a long-term care facility. How do you get back to where you're going? It's that whole spectrum that the American Heart Association they have a nice chain of survival is what they call it. So that's what I do day to day, teaching and helping improve processes.
As an old nurse, I find it fascinating that there's a whole area where it's on life resuscitation. That fascinates me. That just shows how old I am. We didn't have that back when I was in school. One of the things that I deal with, and I encourage my family caregivers to do, is have ongoing conversations with their loved ones about what they want at the end of life, because so many of them feel blindsided when they're suddenly asked to make medical decisions. It's a conversation that needs to be talked about often, and it's not talked about at all. So I was wondering if you could give us some information, like in simple terms, what do we mean by methods to prolong life?
Yeah, the simplest way I would put it would be temporary and long term. And so as a former ICU nurse, I that was years ago, but every day I would deal with temporary, very invasive temporary measures to prolong life. And so think about what the human body needs. We need oxygen, we need blood flow, we need sustenance, we need nutrition, we need all of our organs to work. And so every organ in your body, we have a machine that exists essentially to be able to do the work of that organ on a temporary basis. Some some of those functions end on the long-term basis. So like what I mean by that is your lungs, right? You need your lungs to breathe and so that you can get oxygen in your blood. We have ventilators. And so we can put you on a ventilator. A temporary measure would be a breathing tube, right? And the ventilator pushes oxygen into your lungs, and your lungs brings the oxygen into your bloodstream, and you live. And you think of the kidneys. So you might have a heart attack and your blood pressure drops for a long time. So not only is your heart function debilitated or affected, but your kidney function might be. And so we have machines to temporarily clean your blood. That's what your kidneys do. They filter your blood and take waste out so that you can live and you have all these normal levels. You might get labs checked, and you don't want any of those values to be red, right, when you get your labs checked. And so that's on a short-term basis that we can do that. And then all of those things we have a long-term ability to do. You can be on a long-term ventilator. You can have dialysis long-term. And that's the easiest way for me to think and for me to communicate if I was an ICU nurse back in when I did that. What are your options? It depends on the condition, the primary diagnosis, the organs that are affected in whatever state or condition that you were in. But we have temporary ways to support your life, and then that can be transitioned to long term. And that's what you're talking about, Diane, with the conversations. What am I willing to accept? And I'm happy to continue that with you now.
Yeah, I'd like to people to understand what really is happening in the body as the systems begin to shut down naturally. I want to share with you, Stephen, that there are so many times I hear hospice is killing my parent. And it just, first of all, doesn't make sense, but there's a whole group, several groups on Facebook that address that. So I thought maybe we'd start but with what's happening in the body as systems begin to shut down, and then we could talk about some interventions.
Well, yeah, that's a complex thing to try to dissect, but essentially, every cell in our body, from our heads to our toes, has to have blood flow. It has to have oxygen and has to have sugar, right? That's on a cellular basis. That is a requirement, a prerequisite of life. And when that is not provided, then the cells begin to die, particularly oxygen in a more immediate basis, but glucose, right? Like when I glucose, I mean like food. We need
Yeah.
to eat food. And so, as let's say someone who has a long term chronic condition where the deterioration, the clinical deterioration is on a longer basis, because in the ICU, we're talking clinical deterioration over the course of minutes or seconds, maybe hours, but in maybe easier for people to understand the long term deterioration of the human body. Essentially, yeah, the organs as they are expected to function, that alters, that's changed. In my experience, the quickest, the most substantial effect of that happens really in the cognition of the person. You may not, your liver failing, you may not really notice it early, your kidneys failing, you may not notice it, but especially the caregivers, it is night and day when they start acting different. So when the brain starts to get, and I'm not talking stroke, right? An acute brain dysfunction.
Right.
I'm talking more long term. And so they might start acting differently. And then that might prompt them to, oh, we need to go to the doctor. They're not acting right. And then the physician, the provider might order some further diagnostic testing and say, hey, we have found out, is it a primary problem of the brain? Is it a primary problem of another organ? Because liver failure has crossover and symptoms can manifest as confusion. Kidney failure can manifest as confusion. Heart failure, you can have confusion. Now, it depends. Sometimes kidney failure, you'll notice a little. It depends on I guess, the speed at which that
Right.
organ is affected, which is really the challenging part to try to describe, but I would say that's what happens. The body eventually starts to it experiences dysfunction. And so all of the normal functions of those body parts, those organs, they don't work the way they're intended to.
Right.
And eventually the breathing starts to get involved. When we start to see the breathing affected and breathing becomes hard,
Mhm.
that's usually there is not much time left. That's a problem, especially if they haven't had time to talk about things. And now I can't breathe. Now I can barely have a conversation about how I even feel. Like I can't even describe to you how my breathing is, let alone talk about what am I going to do next month, next year, and what do you want me to sign these papers? What do they even mean? Like you quickly, when you have to start talking about body part functions on an hourly basis, which is a standard in the ICU, you're not really talking about what you're going to do next week, next month, or next year.
That's why I think it's so important for families. I encourage my family caregivers and the seniors to get the 5wishes.org. It's a advanced directive where it
Oh,
breaks
yeah.
down all the body parts and says, when this happens, I don't want this or I want this. And it
Oh,
really
that's
makes
great.
sense. Yeah, I love it. And it's really gives you a chance to have a conversation like, "Hey, dad, you've been diagnosed with cancer, and you're telling me you don't want treatment. Okay, let's talk about what you want." And then I get out the advanced directive and say, "Let's talk about end of life because eventually it's going to come." And it's the same with people that with diabetics or with people with dementia. They start losing their body functions, change over time, and they get worn out. The sugar in the diabetics causes neuropathies and
Yeah.
oftentimes amputations. That's a little hard for families. But and then the people with dementia, they lose their ability to communicate, then they lose their ability for the most part, will stop eating and they change. Or even people with stroke, they have different diets for honey thick, mechanical, thin liquids because your muscles get weakened. So I wanted to address that because the body begins to shut down naturally. And that's when I want to talk about the interventions that sometimes prolong dying rather than living. So I thought we'd talk about that. What would you like to talk about first?
The breathing is the most important thing in life. You can't
Okay.
last very long. So we can talk about that on a short-term basis. You can be placed on a ventilator,
Hmm.
and there are temporary breathing tubes. And usually, most physicians I've worked with, they really don't like their patients to be on for more than a week or two. That's a very
Yes,
long time to be on
that's a
a
very, yes.
because my wife is a speech therapist, and you mentioned the honey thick and the nectar
Mhm.
thick, and even using a straw. There's
Yes,
implications in speech therapy. Using a straw has aspiration risks. And
yes.
so the reason I mention that is because as you're on a temporary ventilator for a long period of time, your ability to speak, the muscles in your throat that allow you to ingest food and liquids,
Mhm.
they experience dysfunction and alteration, and they may not work the same way
Yes.
the way they did before you had a breathing tube. And so the ventilators can give you oxygen and pressure. They make it easier to breathe because you don't always have to be heavily sedated to be on a ventilator. And
Yeah.
there that may cause trauma psychologically because you're not able to speak. So you're awake, but you can't produce sound, you can't communicate. But that's a whole different story. But
Yeah.
as far as the preservation of the life, the prolongation of the life, the decision then has to be made. Okay, how long are we going to keep them on a ventilator? Can they come off the ventilator and breathe on their own? And that is a tremendously difficult decision that physicians, nurse practitioners, physician assistants, providers around the country, around the world make every day. If the determination is that we want to push and have all life sustaining measures maintained, then they have to consider long term ventilatory support, which would require a tracheostomy.
Yeah.
And that is a surgically placed breathing tube. It's in between your throat, right above where your neck comes off of your chest. And that allows you to breathe easier and not have to have the risk. It reduces the risk of a lot of things, infection, but long term, there's potential that you can ingest food and liquid along with that, and that could be the next thing we talk about is nutrition. So
Yeah.
nutritionally, you obviously need to eat. You can't live very many days without eating. Water, of course, not long at all. Food, you can live a little bit longer without it, but not long. So water, we can replenish your hydration with IV fluids. That could be, we put a catheter, a small catheter in your vein, and you can get saline or lactated ringers. These are just fluids. They're sterile fluids in a bag that instead of having to pass through your intestines to get into your bloodstream, they just go right into your bloodstream. And because you need to have hydration in order to, that's another requirement of life. And so that can be then transitioned to a temporary feeding tube. So we can remove the IV, we can put a temporary feeding tube like in your mouth at first, usually in the ICU. If you're ever admitted to the ICU, I hope you're not. But if you are, you'll have a breathing tube and a feeding tube right next to it. And that feeding tube will be used to deliver temporary feeds, like liquid feeds, because you can't ingest like food that requires chewing. It has to be in a
Mhm.
liquid form, as well as hydration. So we'll go from IV fluids, that's the most acute form of hydration, and then the temporary feeding tube. Then the feeding tube can be also placed in your nose. So, like, oftentimes, if patients are successfully taken off of the ventilator, but they have failed their speech evaluation, things that like my wife does, they evaluate their ability to swallow and speak. They may fail that evaluation, but they can breathe without a ventilator. So they have to be on restrictions, dietary restrictions. Like you mentioned, honey thick, nectar thick, those are thicknesses of the liquid. And the thicker the liquid is, the easier it is to swallow into the esophagus and not into your trachea, your airway. Because if you, let's say you break the rules, you don't follow your speech therapist, and you drink thin water, then it can go into your lungs. You can aspirate water, liquid into your lungs. It's not a great combination. You have a high risk of developing pneumonia, which is an infection, and that can put you back on the ventilator because you have an infection in your lungs can't function. And that feeding tube that you would use into the nose can help deliver food and water through into your stomach, but through your nose. And then if for whatever reason the decision that nutrition needs to be delivered long term, then you're talking surgical placement of a feeding tube. So like a G tube or a J tube, that's like the healthcare talk, but it's just a feeding tube, a
Yes.
long-term feeding tube that's placed. It'll come off of your abdomen right into your stomach. Sometimes it can be placed into your intestine, but most it's like a peg tube. And that can be used to give feeds long term, water if you can't drink it, and then also medications can be crushed. So, of course, a pharmacist has to be involved because some meds cannot be crushed, some can. So, you do need to have a pharmacist kind of review the medication lists that anyone is on if they require to be crushed and delivered via tube. And so then the next thing would be, so we talked about breathing, we talked about hydration, we talked about food. The next thing would be maybe the kidneys, the long term. That could
Mhm.
be something. And then I do want to touch on AICDs because that's a little bit more complex. But your kidneys, they can experience dysfunction. Your kidneys clean your blood. And so we have ways to clean your blood essentially using a large IV. It's a really big IV that requires to be placed into a large vessel. Usually it's in the neck or the groin, like your leg, where your hip is. And so I actually used to do all the training for that. I was a ICU nurse educator, and I did the training for nurses on how to use those temporary hemodialysis machines. And so those temporary machines we can use for up to several weeks, actually. You can put someone on temporary dialysis for many weeks. And then if the kidneys don't recover, you don't produce urine, and your blood tests tell us that your kidneys are not really working well, then the decision has to be made to put you on long-term dialysis. But you can live many years if you're on long-term dialysis. Sometimes you'll be put like a perm cath. It's like a catheter that might be coming off of your chest, or it could be coming off of your arm potentially. There's fistulas, which is just a fancy term. It's like a surgically placed or surgically developed large IV kind of. That's a very simplistic way to put it, but that allows you to essentially have your blood taken out of your body to run through a really high grade filter and mixed. They remove the waste and they replace the electrolytes because your kidneys help maintain electrolyte levels. And then they bring the blood back into your body. That's dialysis. And that could be long term as well. And you can live many years on those things. The trach, you can live many years. The peg tube, many years. The dialysis, the 5-year survival rate's a little lower for dialysis patients, but it's not like it's zero. It's you can live, which I'm sure we'll talk about shortly, the quality of life that
Yeah.
becomes impacted. And then the last thing is AICDs or pacemakers. It's a really complicated topic, but essentially, if you have a condition where your heart experiences either a really slow heart rate, your heart rate gets too slow. It's like a pacer in a race. Like if you ever run like a foot race, like a marathon, there's like pacers help you keep you in your time. That's what a pacemaker does. Is if your heart goes too slow, the pacemaker says, nope, you can't go any slower than this. If it goes faster than the pacemaker, that's okay, but it cannot go slower than the pacemaker. And people with pacemakers can live decades. That really depends on honestly, the amount of time that the battery lasts, and also if there's any complications. Everything has potential complications. AICDs are a little different. If you have a heart problem that not only maybe your heart can go too slow, but an AICD is automated internal cardioverter defibrillator. All that means is that if your heart rhythm that normally has to be organized gets disorganized, this little device in your chest can help it get reorganized. Now, it shocks you, it defibrillates you, which is a shock. It's like literally electricity that's sent to your heart. It's always monitoring your heart, and it's internal, it's not external, it's surgically placed. And you can live many years with those as well. Of course, all of these things require frequent visits to the doctor, you maybe even visits to the home health, things like that. But you can live a pretty long time with all these measures. That's where the difference between quantity of life and quality of life comes in.
Before we go into the quantity versus quality, can you talk us through what happens during when CPR is occurring, especially on an older person? What happens, what the body reacts? Can you discuss that a little bit for us?
Absolutely. Yeah, this is my bread and butter. I've probably read 200 articles on cardiac arrest for my PhD studies. When you're having a heart attack, because I do want to take the opportunity to differentiate between a heart attack and cardiac arrest. When you're
Okay.
having a heart attack, think of a heart attack as, let's say you're doing bicep curls with a 5 pound weight, and then someone just whacks your bicep really hard. You can probably still lift the weight, but it's pretty hard and you're struggling, but you're still going to be able to pump it a little bit, right? That's like a heart attack. Your heart has an insult, right? An artery is blocked, the muscle is affected. It's still able to pump most times, but it's pumping pretty weak. You're going to have symptoms, of course, chest pain. A cardiac arrest is not only am I not pumping that my muscle anymore, my biceps not pumping, it's stopped completely. It's complete cessation of heart and lung function. So that's defined clinically as death. That's end of life. So in the hospital setting or in the out of hospital setting, we would provide the way we train healthcare workers is the first thing is you want to establish whether or not they're responsive because someone could just be in a deep sleep. So you don't whack them, but you tap them really hard. You shout at them. There's no eye opening. There's no arms and legs moving. And then they're then trained to test for a pulse. So you palpate, you feel with your fingers. They feel for a pulse. At the same time, they look for any signs of breathing. And those are immediate signs of life. Okay. So they're unresponsive. There's no immediate signs of life. They're then trained to start chest compressions. And so what this is, we put our hands on your chest. We position ourselves, our bodies over your body. Let's say you're laying on the ground or laying in a bed, and we put our hands right in the middle of your chest and we push really hard and fast. And that's chest compressions. So you would get chest compressions if you were in a hospital or in the community. At the same time, we have to try to breathe for you. So there's all sorts of devices to deliver oxygen, bag valve mask, which is just a mask that's connected to a kind of this bladder of air, and you can squeeze it and it pushes air into your lungs. It forces air into your lungs. There's pocket masks. That's a more portable version. It's just a mask that you put on someone and you can use your own lungs to breathe for them. It's like a barrier. It's a little protection from certain illnesses, viruses. And then we would have to then determine if your heart rhythm is shockable or not. So you're getting chest compressions, you're getting air pushing to your lungs, then a temporary or manual defibrillator, because we talked about AICDs. Those are long-term defibrillators that are implanted, but we have temporary defibrillators. In the shows, you might have seen them have those hand pads that they rub together and they say clear, shocking. So now the technology is much more portable, much smaller. It's these adhesive pads usually that we will put on your chest, and we will evaluate your heart rhythm and to see if it's a shockable rhythm, so that kind of disorganized state. And so we would deliver energy. So essentially, when someone's in cardiac arrest, the most important thing is that the way we train healthcare workers is you don't stop compressions. You keep doing compressions, because the longer you're off of the chest, not delivering blood throughout the body manually via chest compressions, the more chance that they won't survive. And they won't survive and they'll be the same person, because that's our goal. We want them to be alive and be the same person that they were, and not in a vegetative state, which we would say like they're in a coma, but that just means that they're not neurologically intact. There's huge dysfunctions or deficits. You definitely may not be able to walk. You may not. We don't honestly know a lot of times. I took care of a lot of patients post cardiac arrest in the ICU, and there's only so much you can ascertain from a physical assessment of someone. Of course, there's MRIs, there's EEGs, there's so many diagnostic tests, and there's more and more coming out as to how you can evaluate someone's neurological status after cardiac arrest. But that's the most important thing. If after a cardiac arrest you are resuscitated, meaning you have a pulse that's restored, the pulse that you can feel on your wrist, it comes back without us mashing on your chest, having to breathe for you or defibrillate you, then the question becomes, okay, what is the damage? Has this person experienced detrimental neurological deficits that would, of course, elicit conversations about, is this how they want to live? Because all of those things that I talked about several minutes ago about the temporary measures, if you do experience cardiac arrest, you are going to have those. And then the decision will have to be made. What do we take away? Do we take away all of the things? Do we take away one at a time? And that's where quality of life comes in. Of course, if we in the hospital or out of the hospital know ahead of time that someone we can talk about like living wills or advanced directives, that's hugely helpful. That helps a ton, because then there's no decision. That's what they wanted. They wanted this. And so we just follow through with their wishes that have already been outlined and defined for us.
And that's what the purpose of this conversation is, to
Yeah.
let people know. Now, one of the things you didn't mention is when you're doing CPR, families don't understand that ribs get broken.
Yeah.
There are things that happen to your loved one going through this that is going to increase their pain levels and can cause a lot of problems. Can you address a few of those things that?
Yeah, I didn't want to deter people, but I understand the purpose of your podcast. But yes, CPR has tremendous side effects. That's not the things that we really teach. We teach more so how to do it, but you can experience primarily, broken ribs. I was actually just at a community CPR training in my community yesterday, and I was training lay persons, people that are not healthcare. They were honestly surprised. Wait, you do break ribs? I have done compressions numerous times on adults. I haven't taken care of children, but adults. And it's pretty normal to feel popping and to feel the ribs break. That is a side effect, but the benefit is that you hopefully live. You can experience bleeding, internal bleeding around the heart. The lungs can experience direct trauma from the repetitive motion of the chest compressions. The liver is a large organ on the right side of your upper abdomen, and your ribs can cause laceration, or this means cutting. It can damage your liver, and your liver is a very visceral organ. What that means is that there's a lot of blood that has to
Mhm.
be sent to your liver. It has huge blood vessels. And if your liver lacerates or gets cut, you also experience internal bleeding. That a lot of times the injuries in the science tells us that a lot of times these injuries don't require like surgical repair. They'll just
Mhm.
repair on their own. But if they're very extensive, then they might require additional surgical procedures. So like after you're resuscitated, if it's they can do ultrasounds or CT scans and they say, wow, there's a lot of internal bleeding, we might need to go into the operating room and help fix some of this. And then, of course, those are just the physical, like immediate side effects. There's essentially when you're in cardiac arrest, every single organ in your body, including your brain, has inadequate blood flow, right? It's like your kidneys will have dysfunction, your liver, if your pulse is restored. And so those are just the immediate side effects. And yes, it's not pretty, but that's the best thing. The best intervention that we know of is immediate chest compressions and high quality CPR and rapid access to a defibrillator. Those are the interventions that have been shown in the science to lead to the best chance of survival.
Patients used to get burns from
Yeah.
the paddles. Um, is that still occur? Because it sounds like they're doing something totally different with the pads.
They can, no, it's
Okay.
not as common. It can occur, yeah. The skin, when those pads that we use to defibrillate, it depends on the type of cardiac arrest because there's different types. But if it's like a
Right.
shockable cardiac arrest,
Yeah.
yeah, if you are shocked many times, the electricity essentially we put the pads on the outside of your chest. The electricity has to travel through your skin, through your ribs, through all the tissue to get to your heart. And if that happens over and over again, the skin exteriorly, it'll
Yeah.
burn, it'll erode sometimes. We have definitely seen that in patients that were just in what we call refractory ventricular fibrillation. It's a heart rhythm that's not compatible with life. If you're in this heart rhythm, you physiologically cannot be alive, and it requires electricity to reverse or fix the heart rhythm. So yes, I have seen that. It's not as not I guess the reason I didn't mention is it's not reported as frequently in the literature, so maybe the
Mm.
technology has gotten better. I think with adhesive pads, because those paddles that they used to use, they
Yes.
didn't always make a good contact with the skin. But
Yep.
now that we have these highly adhesive pads that are
Mhm.
placed, we train people. I train people like you have to put the pads on correctly. I'm really adamant, and when I train healthcare workers, because that will happen. And so I think
Mhm.
maybe the technology has evolved that we see that less.
Oh, it absolutely has from when I've been a nurse for 54 years.
That's
I was in nursing in the dark ages.
I was 10 years as a nurse in December of just 3 months ago.
Oh.
So
Oh,
that's a long career. That's great.
yeah, yeah. And I like what I do. And my goal now is to help seniors remain in their homes and the family caregiver, help them navigate the medical delivery system. And one of the things that is so important is get that advance directive in place and
Yeah.
talk about all of these systems. Again, fivewishes.org has an amazing, a very comprehensive advanced directive. It's about 5 or 6 pages. It opens up and asks you questions. If this happens to you, do you want this? And that's really important. Now, can we talk about artificial feedings? What are the realities caregivers should understand about them long term?
The things that come to my mind are the site. You'd have to maintain the site that the temporary feeding tube is placed because it requires surgery, it requires cutting into the skin. So the thing that comes to my mind is that, and this is probably my nursing judgment, is like, what's the surgical site? But
Yeah.
you have to maintain it, you have to clean it, make sure that it doesn't get infected. The next immediate concern would be dislodgement. That could potentially be life threatening.
Yes.
Infection, that's I guess how they that's what's coming to my mind. That's probably how they train nurses. Like, what is the most life-threatening thing? And I think about
Mhm.
that first. So bleeding, assessing the site, but that's after many days and weeks and months that
Yeah.
usually subsides as the skin kind of adheres around the tube. But it could be dislodged. Dislodgement can occur. That can be life-threatening because essentially the contents of the stomach or the feeds are going into the peritoneum, which is just it's like your belly, but it's like not your stomach belly. It's like the area around your stomach, which is
Yeah.
obviously a huge issue. And then there's, of course, the availability of the tube feeds. So whatever the feeds are, they might be placed on a pump. So like continuous, they might get bolus feeds, which is like maybe let's say every 4 hours you give them one bottle of this.
Yeah.
So making sure that you'd have to gather those feeds, make sure you have a supply, just like you have to go to the grocery store to buy food in your house and cook. But the food for that person is in a different form. It's in a liquid form. And then the next thing would be like electrolytes. So, is of course the caloric demands of the person being met? Is that enough food for them? You have to make sure you're checking their weight, that they're not losing weight. A lot of times dietitians aren't too concerned if they're gaining weight unless it's excessive, like just very overweight. But the electrolytes too have to be checked because like in order to survive we have to eat food has calories, sugar, potassium, sodium, magnesium, calcium. These are minerals and vitamins that we need in order to survive. And so making sure that tube feed or whatever the formula is that person is getting is meeting the needs nutritionally and calorically of that person.
We've talked about mechanical ventilation. I'd like to talk about what limitations it is in somebody who may have a serious or terminal illness. Because families are afraid to take them off. They think they're killing them. Same with tube feeds. They feel like the family feels like they're causing death.
Yeah, it's really hard to change your perspective. It has taken me years to see this, but, and I think my interaction with palliative nurses has
Mhm.
helped. I have
Yeah.
sat in consults. So like I was the ICU nurse and I was with the caregiver and it was that initial meeting with the palliative nurse. And honestly, my interactions with them has taught me a lot of what I know about end of life and those
Yeah.
conversations.
Yes.
They're not easy, first of all, but the way that I would frame is we are all on our way to natural death. And these interventions that we can put in place can prolong that time. But it doesn't mean that it's not going to happen. And then when we experience illness, our time may shorten. And of course, we can put these temporary things in place that prolong that. But I think the reason I mention that is because that person's natural death it's inevitable. It's always going to happen.
Yeah.
And all we're doing is, well, by removing them on the ventilator, by taking the tube feeds off, we're just letting these natural events happen
Yeah.
with, honestly, with dignity, with pain control, potentially. You're not waiting until that bitter end. That person you're looking at isn't the same person you knew when they were before they were in that state.
Exactly.
That's
Yeah.
And it's not about losing hope. People think, and it is hard. I am not negating how hard it is to see a loved one's life end. That's extremely hard. I had an aunt pass away a couple years ago, cancer that came back, spread to her brain, and she was in her late 70s and they were talking about chemotherapy in her brain. I didn't even know you can do that. It's called
Yeah.
intrathecal
Yeah.
chemotherapy.
Yeah.
I don't know much about neurology. I'm
Yeah.
cardiac. And I didn't know that. And I was like, there is no way. And I was the nephew, so I didn't have decision making. But I would have been like, there is no way that's going to help her in any way. The cancer that she had.
Right.
So I was very in favor of allowing her to pass peacefully. But the reason I mention that is because you want to talk about hope. So we have hope right now. If you are listening to this, hopefully, you have hope that you're going to live a long and prosperous life.
Yeah.
So when someone is at the end of life, we don't lose hope. We're going to shift hope. We're going to shift hope to them. Now we're going to have a dignified and as high quality end of life. So you're still having hope, but it's shifting
Yeah.
so that the person that is maybe on their deathbed, especially if they have the resources available to them for these comfort measures. Maybe they have pain meds, maybe they have anti-nausea medicines. They can maybe be put on a little bit of oxygen just for symptom relief, not for prolonging life. There's all sorts of things. And then, of course, that's hospice, right? So we're talking about hospice, but I wanted to mention that because that's me talking is just as a human being, not as an ICU nurse. That was my own
Yeah.
family, but I was very much in favor that she had lived a very long life, but the likelihood that she would come back to a quality of life that she felt like she wanted to have,
Yeah.
it was so small, that chance of that happening. So I was in favor of her going peacefully and trying to remember the times that we had that I remember as a younger kid, because she was like a grandma, the way my family is. She was my aunt, but she was almost like my grandma. And so I really tried to remember that instead
Mhm.
of seeing her in the state that she was in. But don't get me wrong though, that is extremely hard. I don't want to say, oh, there, just let them go. It's fine. They'll be painless. And it's also, it may not be painless, but we try to control or limit the pain that they might experience at the end of life. But that's my personal experience with it.
Seniors and family caregivers don't realize that the interventions that they introduce, mechanical ventilation or artificial feeding, prolongs dying sometimes rather than living.
Yeah,
And
that's
it
a good
does.
way to put it.
Yeah, and it causes increase in pain and suffering, and it doesn't encourage a quality of life. But some people are so fearful of death.
Yeah.
And one thing that you mentioned was palliative care, and we don't use palliative care or hospice enough in this country. Palliative care, as soon as people hear palliative care, they think, "Oh my God, we're going to die." Palliative care can also be a bridge to getting better. It's just that there are times when you're not ready for hospice or you don't want hospice, but you want to have comfort measures. And the nurses with palliative care can make that happen for you. And there's also support of a healthcare professional as your family member goes through their death and dying process.
Yeah, the palliative care thing, I really did not get a good understanding of that in my nursing orientation. And honestly, there's been a lot in the last 10 years about
Mhm.
palliative care in the ICU. That's my exposure. And so we actually will have palliative care consults while patients are still in the ICU. And the data, the results are pretty incredible. People are in the hospital less days. Their quality of life is better. And then what you can infer is that they're not getting treatments that they wouldn't want. They're not getting these prolonging. And you
Yeah.
talked about the limitations of ventilation. Sure, you can survive on a temporary breathing tube, but eventually the human body is not made to lay in a bed on a ventilator for days and
Exactly.
days. We are
Yeah.
physically not made for that. They will deteriorate. They will have that's a fact. They will eventually have some sort of complication on a ventilator, whether it's a pressure injury, whether it's a DVT, a clot in the leg, whether
Mhm.
it's infection, skin breakdown, even of the mouth, even just your mouth and the area there where so they are great pieces of medical technology. Ventilators are incredible, right? Especially the COVID pandemic, there was a shortage of them. And but they are not. I personally, so I don't have this written down, but personally, I would accept a ventilator and a trach conditionally if my physical ability wasn't impaired and it was less than 12 months. So essentially for me, if I cannot walk and the chances that I won't be able to get up out of
Mhm.
bed are low, if they're low and it's going to be forever, it's permanent, then I personally wouldn't want that intervention done. And that's my
I agree.
experience of seeing it, seeing
Yeah.
you mentioned the pain. It's a really difficult reality to live. We say it, oh, yeah, I'm fine with it. Man, like
Oh,
seeing
yeah.
people, I've spent time in our progressive unit at my hospital, and everyone has a tracheostomy and they're
Yeah.
severely physically debilitated. They almost all have pegs. You can't even think about chewing food and like drinking whatever you like to drink, water in your mouth. You can't do that with a ventilator. And physicians and doctors are going to be less likely to they'll probably share that with you, that they feel hesitant. Hey, with this advanced illness, I am not sure that we're going to get anywhere. This may not be the best approach. There are limitations. It's not a forever thing. You wouldn't want it to be a forever thing. So I think it's great. What you do, Diane, is really great as a former ICU nurse. That tool that you mentioned,
Yeah.
like that would be helpful for even ICU nurses to know about because
Yeah.
that enables them to communicate with patients more directly, more clearly, not just
Yeah.
patients, but the caregivers, because the caregivers are put in a really tough spot
Yes.
because they love that person. They're there for them. They want what's best for them. And maybe that can clash. Maybe what the
Yes.
patient wants and what they want can clash. And those are not, there is no black and white answer to that kind of dilemma, right? What happens if we disagree? It's just you have to communicate, you have to
Well,
understand knowledge. Those things can help.
I encourage every senior to choose a power of attorney that will honor their wishes. And only
Yeah.
one person, not two, because when you get two power of
Yeah.
attorney share, they fight and argue, and one will say, well, here's a perfect example. I had two sons. My oldest son, we were talking power of attorney, and I said, Casey, my youngest son, I'll make him the power of attorney for healthcare. And the first thing out of Jeff's mouth is, Mom, you're going to have a hangnail and he's going to pull the plug. It's just silliness. And people don't understand that when you are able to express your wishes, then we honor your wishes. But that power of attorney is in place when you are no longer able to express your wishes.
Yeah.
They are your advocate, and that's really important. And the other thing I want to talk about is the feeding tubes. People don't understand that with a feeding tube, they have to be sitting up all the time.
Yeah.
Your body goes through a response of decline. And as the system starts shutting down, like your inability to swallow, people will drool, and it's actually you're force feeding them. And
Yeah.
and then there's always in and out of hospitals for aspiration pneumonia because
Yeah.
the fluid went up into their throat and it went into their lungs. There's those things. Oh,
Absolutely. I've seen that recurring pneumonia, and
yeah.
as a nurse, it is hard to, you're doing your job taking care of them, right? And getting them where they are expected to be. But as a person, it's not uncommon for nurses to experience moral injury, like what they believe is right is not being done. And yeah, and you're talking with the drooling and having to sit up. That's
Yeah.
very advanced. I guess that would be outside of the hospital. I'm
Oh,
very
it
much
is.
so. Yeah, I
In
mean,
nursing homes and
yeah,
yeah, that's
that's
where
really
I've
hard to
seen it.
see.
Yeah, and families don't understand. I actually
Yeah.
had I was a supervisor in a Jewish home, and I got a call that this 104-year-old man who had a feeding tube was not doing well, and there was no DNR or anything on the chart. And so I had to call his son, who was a doctor. And I said to him, hey, there's no DNR. Can I get something? Can you come in and we can take care of this? Because we don't want to set him out because they'll do CPR and all that. And he insisted that he be sent out. I was that, you talk about moral injury. I was like,
Yeah.
I felt so bad for that old man. He's 104 and they're going to do all that to his poor little body. And he did eventually. He died that day, but I just was shocked. And then I wonder what kind of doctor would do that, but who knows? But
And
no judgment.
I will say it is hard to, because nurses do this sometimes. They're able to see things objectively and say,
Yeah,
wow, this person is in a really bad state. And
yeah.
it is hard for caregivers or and family to see that,
Mhm.
because my dad, the one that raised me, the one that took me as a
Yeah,
kid to X, Y, and Z.
yeah.
But yeah, I think that visiting family in those homes would be helpful to see. My wife's grandfather passed
Mhm.
away shortly after the pandemic. Her grandmother passed away in 2020 from COVID. She refused
Oh,
the ventilator, And
Mhm.
I was a little upset about that because I really think she should have accepted the ventilator, but she was of sound mind and she said, I don't want it. They took her off. She was on a mask that
Mhm.
was just attached to her face. And I was actually I was in favor of her accepting the life prolonging just
Mhm.
for to see, but she said, I don't want it. And she passed away that day. And it was very hard, but we respected her wishes. My mother-in-law did, but the
Mhm.
grandfather passed away and seeing him, he passed away of dementia, and it was very hard to see that. I have more experience with delirium, which is like acute confusion, but
Yeah.
dementia is a very challenging. One of the worst things some people have said to see your because it's so long and it's so slow. And then some days they're good and you're like, maybe we're getting better. And then the
Yeah.
next day and then the next day. And it's like a roller coaster is what I've been told that it feels
Yeah,
like.
that's what they call it, the long goodbye, because
Yeah.
and I will tell you that a lot of caregivers, after taking care of somebody with dementia for a very long time, they feel guilty because they feel relief that they've passed. And it happens.
Oh,
Yeah, and there's nothing wrong with that. It's a normal human feeling because you put so much time, energy, and effort. You've given up. I don't know if you know this or not, but 63% of family caregivers become seriously ill or die before the person they're caring for
wow.
because the stress is terrible.
Oh, yeah.
And there's lack of support, and they're the second an invisible patient. They really are when they're taking care.
I didn't know that, but it's not surprising and it makes sense because when you know your loved one is ill, acutely
Yeah.
ill or long term, how it's like hard to sleep. It's hard to eat and do things for yourself. And so
Mhm.
then you become that's that self neglect.
Yeah,
And then
it totally. Yep,
that
yep.
that's really hard. But
Steve, what would you say to caregivers who are carrying guilt or fear about making these decisions?
if they feel guilty, honestly, that's a hard one. I think that having a support system, having a friend, having a family member to talk to,
Yeah,
I would also, I don't know if it exists. I don't know this world. Maybe if there's support groups, if
there
you're,
are.
yeah, I mean, that right there is probably gonna be one of the best things. If you are experiencing something hard in life, if you find someone else who's going through that hard thing and you can communicate with them, you can relate, it helps you. It helps everyone. So to me, if I had met a caregiver and they were struggling and they're out of the ICU and especially with these decisions, because in the critical care setting, decisions are a little bit more black and white, but in the long-term care setting,
They're
it's
not.
not black and white. I would try to reach out to supports that you have, if you have family or friends, if you have siblings, cousins even. I would try to
I
find,
Yeah, and I encourage if you are a person of faith, reach out to your pastor, your
yeah,
rabbi.
your spiritual beliefs might help a
Yes,
lot.
yes, and that is also a way to get through what you're dealing with. My great-grandfather had last rites 7 times, and every
Wow.
single time, my little aunts, my great aunts would bring out the tea service, and everybody would sit around, and I can remember him laying in the dining room on his bed, and all of a sudden, he would get up and say one time he woke up, he said, as they think he's dying and the priest is there. He wanted to know where his new suit was because he wanted to see if it was back from the tailors. God, he was
Wow.
just too ornery. God wasn't ready for him yet. But
Yeah.
Steve, this has been very enlightening, and I
Thank you.
really appreciate your approach to end of life care. And I wish you much success in your PhD.
Thank you. Yeah, and I learned a lot. I don't know everything, and so those resources that you mentioned, I would learn a ton from that because my experience is just mine, but I'm happy to share it and I hope that it does help people.
You have a podcast. Yeah, your podcast. Can you share a little bit how they can find you if they want to listen to more of your information?
Absolutely. I have a podcast called Researched RN. I created this podcast for nurses, clinical
Mhm.
nurses, bedside nurses, but anyone can listen. It's available publicly. I summarize research articles that are pertinent to nursing practice with no kind of focus on any specialty. I try to pick different things. I have had end of life articles that I have discussed, like
Mhm.
fundamentals of end of life communication for nurses, what nurses can do to communicate at the end of life.
Mhm.
I had an episode on supporting the caregivers of hemodialysis patients. So what are the interventions that those caregivers can be provided with to support them to want to continue hemodialysis for their loved one? But you can find it anywhere that you get podcasts. Researched RN. It's for nurses, but anyone in the public is absolutely welcome to listen to it.
Some of us old farts don't mind listening to something new and different and learn and still learn.
Yeah.
Yeah.
Thank you.
Thank
Appreciate
you
that
for your
plug.
time.
I
Thank you for
appreciate
your
the
time.
opportunity. Yeah, thank you so much.
To my family caregivers out there, you are the most important part of the caregiving equation. Without you, it all falls apart. So please learn to be gentle with yourself and practice self-care every day because you are worth it.